Okay, so welcome to this presentation on low back pain, which I've titled Best Practice Management. My name is Jack. I'm Jack Jeyaston. I'm sure a few of you have met me before if you're clients at St Leonards Physiotherapy, but if I haven't, it's not nice to meet you. I'm sure I'll see you around at some other point. Um, and yeah, as I said before, for those that are just joining, you can certainly ask a question in the chat bar, and there should be some time at the end where we'll go through those answers if they haven't been answered already during the presentation. So first, just a little bit about myself. So I've been at this practice, St Leonard's Physiotherapy, for 8 months now, since the start of the year. But I have been a physiotherapist in the private practice world for the last 6 years. I did a 3-year undergrad in exercise and sports science, and then went straight into a master's degree of physiotherapy, which was another 2 years, so 5 years all up. I have got a couple of areas of interest in the physio realm. I do like the sports physiotherapy side of things. So you're rehabbing, anywhere from your weekend warrior athlete to your more amateur or like semi-professional athlete. I do like treating like runners as well. I'm a bit of a runner myself, so I like the running side of things. But I also like to generally treat and rehab, the post-operative patient, maybe someone who's had a rotator cuff repair, a low back surgery, hip or knee. So I like that side of things as well. My hobbies, I like to stay quite active and fit, so I do enjoy running, uh, going to the gym. I try and rock climb once a week. Um, some of my fitness goals for next year, I want to do one of those Spartan half marathons. That's one of those crazy obstacle course events where the distance is a half marathon, so 21 Ks, but throughout the Ks, like every K or so roughly, there's an obstacle you have to undertake, whether it be a crazy monkey bar obstacle, having to jump over a wall, carry a sandbag over your shoulder. So quite grueling. Um, so I'm in the midst of training for that now. I also want to have a go at doing the Sydney Marathon next year. That just went by in September. It's normally every September here in Sydney. There was a lot of traction this year with that, so I want to get on board that for next year. But I also enjoy, going on hikes and going to the beach with friends and family. But yeah, lots of based things, I guess, realized in those hobbies. Okay, so a bit of an outline on what we're going to be covering tonight. So amongst low back pain, we're going to have a look at the prevalence, how common it is in society here in Australia. We're going to have a look at some of the structures that are causing your pain, just to give you a bit more of an understanding of what we look for as physios. Then we're going to look into a bit of imaging, which is can be a bit like controversial in the physio or the medical world about how much people get imaged these days. And that kind of leads us into talking about chronic pain and the pain system, which has a big influence on pain, but especially low back pain. And then diving into the psychological and sociological factors that are associated with back pain, which a lot of people don't realize. We're going to spend a bit of time trying to bust some myths, some common things you might hear out there about the low back to hopefully give you a bit more confidence in your in your spine. And then we're gonna touch on a few exercises and different treatments as well. So I know that those are always good take homes to get from these kinds of things. We know what physical things you can be doing as exercises that could help you. Okay, but here are some fast facts about low back pain in Australia. So 1 in 6 Australians, as of well, right now, currently, have low back pain. So you can think that that's obviously in the few millions, several millions. That's quite a lot of people right now that have low back pain. And about 79%, so that's what, 4 out of 5 people will have low back pain in their lifetime. It's already those numbers are pretty big. It affects a lot of people. Um, but what's unfortunate is this next stat: 50% of people will have a reoccurring low back injury in 1 year. So it might get managed, quite well the first time round, which is great, but for some reason we're seeing that there's a massive reoccurrence rate within 1 year. So something in that long-term management plan probably isn't getting addressed as well as it could be. And these next few, really just give the insight on how much of a burden it is on, I guess, Australia's health system. So it's the number two most common problem that's managed by GPs. Uh, it's the leading cause of presentation to emergency departments in Australia. So you can imagine, all the people that are kind of, using up those systems there can take a toll on the health system. The low back is the most scanned part of the body, so it's where we get the most images, more like MRIs, X-rays, and so on.
It's recording. What do you want?
Oops, sorry.
What are you doing? It was okay before you clicked.
Okay, I think we're good. Okay, so yeah, the low back is it's the most scanned part of the body, MRIs, X-rays. So this kind of leads to this last point here. The total treatment of low back pain is up to the $5 billion a year, which is a massive amount of money, and really a lot more should be being done to try and reduce that figure, because as you can all agree, that money is probably a lot better spent elsewhere.
These people
Okay,
are asking questions.
all right. So now we're going to look at some of the misconceptions around low back pain. So these are things you might hear, in day-to-day conversation with people or on TV. Um, and you might hear things like, "Oh, my back is fragile," or you might think that my back is fragile. My disc can slip. Um, Bending of the spine is bad. I have to always be careful when lifting. My MRI shows that my back is damaged. These all kind of give the mindset that the back is weak and that we have to be careful with day-to-day things to protect it. And this can lead us to using the back even less, making it more sensitive, which only seems to exacerbate the issue. So by the end of this presentation, hopefully we can reset this mindset and think more positively about the back. Uh, but firstly, I just want to dive into some of the main structures that could be causing your pain. Excuse me, your pain. Uh, Now, I'm not expecting you guys to be physios by the end of this, but I think it's a good idea just to have an understanding about the sources of your pain. Hopefully, even make you less worried about pain episode. So we kind of split into 3 categories. That's what we kind of look for as physios: serious pathologies, nerve root compromises, and non-specific low back pain. So we start with the serious pathologies. These account for like less than 1% cases to what we see. So there are things like cancer, infections of the spine, fractures, and of course in our initial assessment we screen for all of these. Um, and if we do happen to come across one of these or are suspicious of something like this, and that's when we would refer you to the necessary department or specialist. But yeah, they're very, very rare, those kind of things that we see. And then next we have what they call a nerve root compromise, which accounts for like 5 to 10% of cases that we see here in the clinic. And that's really to do with, the main structure is a nerve exit in the spine that gets compressed. And that causes, one or a combination of pain, weakness, pins and needles, and numbness, and is often going down the leg as well. So looking into that in just a little bit more detail. So examples of things that can cause something like this are like a bone spurs or a disc bulge. So you can see here on this image on the right, in the red here, there's a highlighted nerve that's kind of being compressed by this herniated disc just here. And you can see this is the pain referral pattern as an example that you can get going all the way down to the leg to the bottom of the foot. But what we know is that rarely these nerve root compromises can be of serious nature. Um, signs of a serious one would be where there's very large reductions in strength or a loss of reflexes. So there's a large loss to that signal strength of the nerve. Um, and this is where we would refer to like a specialist to investigate, or an MRI if we were, really concerned about the patient. But these are, quite rare cases. They actually, Harvard had a good study looking at this, and they claim that up to 90% of patients with these nerve root compromises can probably get better within 6 months with just conservative treatment. So 10% of them are kind of in that more serious category that need to, get referred on to a specialist. But the other 90% should be managed with conservative management through physio, medication, and other kind of avenues. And this is just a good example here, this study, showing exactly that. So here, this is looking at um, people who had surgery versus people who had conservative management for treatment of a lumbar disc herniation, so like a disc bulge in the spine. And it followed these two treatment groups over a long period of time. You can see here on the x-axis, I should say, up to 6 weeks, 12 weeks, then up from, 1 year to 2 years, expanding out to that. And on the y-axis here, we have pretty much a patient's pain level. So the very start, obviously, pain is quite high, but then throughout the treatment, the pain level gradually reduces. Now, the black here, this black line group, um, this is the group that was treated conservatively, so no surgery. And the gray line group is the patients that did have surgery. So in the first 6 weeks, you could say that the treatment group that did have surgery, they had a faster response in that initial 6 weeks to a reduction in their pain levels. As you can see, as it expands out 12 weeks and then really expands out to 1 year to 2 years, it pretty much ends up at the exact same um, part at the very end. Um, and this is the same kind of trend we saw. So this is just a pain graph, but we saw pretty much exactly the same kind of trend for those neurological symptoms. So like the pins and needles and numbness down the leg had the exact same path, and people's day-to-day function or activity levels also showed the same path. So it really showed that a lot of people are probably getting surgery when really they just persisted with physiotherapy and conservative management, that they probably would end up in the exact same place. So it gives us a really good indication that your back is strong and robust, and it can heal. And the injury, probably isn't as bad as you may not, or as you may think at the very start. Okay, and then we go back to pretty much the other 90 to 95% of cases here on the right. They call it non-specific low back pain. It's a bit of a mouthful. Really, what it's just saying is that it's pretty much everything else but those first two that we talked about. So it's not anything of a serious pathology. Um, it's not a nerve root being compromised causing those symptoms down the leg. pretty much everything else outside of that. And that's where it's normally of a musculoskeletal origin. So it could be a joint, could be a muscle. It could be like a minor disc problem that I've written here, but you can get strains of the disc without having the the nerve itself being compressed, causing those symptoms down the leg. But really, most of these they rehab quite well in the clinic. Um, so this should hopefully give you an idea that, out of what we see, a very large amount are always in this kind of non-serious category, this non-specific low back pain. And we see really quite good results most of the time. But unfortunately, as we get into presentation more, there's some factors that just always in the background that just lead to rehab being longer than it should. But really from this, in summary, majority of low back pain should be treated conservatively, and this is written by the Medical Journal of Australia in 2022. So spinal surgery has a role in alleviating radicular pain, so that's that nerve root pain. And disability resulting from neural compression, or where back pain relates to cancer, infection, or gross instability. Spinal surgery for all other forms of back pain is unsupported by clinical data, and the broader evidence base for spinal surgery in the management of low back pain is poor and suggests that it is ineffective. But unfortunately, though, that's what the evidence shows us. But unfortunately, we're still seeing, surgery is quite a common thing out there. This graph here shows over the past 25 years that, the amounts of spinal surgeries we see is on the rise. The green bar at the top here, this is decompression surgery. So that would be for something like one of those nerve root compressions. So you try and decompress that nerve to give it more breathing space. That's on the rise. On the brown here, those are fusion surgery. So those are really quite invasive surgeries where they pretty much take out the whole disc that's between two vertebrae, essentially making it one vertebrae from two. That's why they call it a fusion of those two vertebrae. Um, that one's going down in the last few years, which is good. But just from looking at this graph, the fusions could be going down, but they could be being replaced with these decompressions, which is going up. So, the general trend is that there's still more surgeries than we would probably, like. Um, so one of the main reasons why we unfortunately still see lots of surgeries is imaging. Now, imaging is often overprescribed, unfortunately. It's received by about a quarter of patients in primary care, and about a third of patients in emergency departments. But we know that routine use of imaging, should really be discouraged unless we see altering features uh, or we suspect one of those serious pathologies like we touched on before, or we feel like it's likely to change management of how we treat the patient in the clinic. And the reason for why we don't like to use it that much is we know that the findings on a scan are often poorly correlated with symptoms, because we can see lots of incidental findings on a scan that can lead to unnecessary worry for patients, and this can trigger additional tests that are of little clinical value. So a really nice thing I like to reference patients to, and there's a lot of numbers and jargon here, so I'm going to break it down. This study looked at, they pretty much took, thousands of people in the general population who had no back pain. So that's what they call asymptomatic patients. These people had no back pain, no symptoms of pain, pins and needles, numbness, no symptoms of weakness. Okay, just healthy day-to-day people, and they all did an MRI of their low back. So let's take the 50-year-old category. Okay, so what this shows us, and we'll go down to disc bulge as an example. So this is saying to us that 60% of people in their 50s who have no back pain at all will actually have a disc bulge on their scan. And you can see that this percentage, this number actually goes up by the decades for pretty much all of these things that we can find on images. So it really just shows us that you can't just look at someone's scan and say that that is causing their pain. When we have all these people who have no pain, have the same similar thing on their scan. So this is where it really becomes critical to see a physiotherapist so we can do a thorough screening and assessment through you and actually work out if that potential disc bulge on your scan, is it actually symptomatic? Is it causing you pain or is it potentially not? Unfortunately, a lot of people will go straight to a specialist, get an MRI before even seeing a physio. Whereas really physio should probably be the first point of call for anyone with low back pain. So we can actually help work out with you where what the source of your pain is. Um, so this means that patients' concerns of something serious, can be addressed by sound education without the need for imaging, hopefully. Um, Because we know treatment for most cases of back pain is going to be the same whether imaging is used or not. And what they've shown is that those that do have unnecessary imaging will often have a delayed recovery. Because we try and tell patients that pain is less likely from these incidental findings that are on your scan, and more likely it's actually coming from one of these non-specific low back pain categories, or something like a muscle strain or a joint strain of the low back. So yeah, in summary, if you have low back pain and you're unsure about where to start, see a physio first. We can do a thorough screening on you, hopefully rule out any serious pathology and get you on the right track. But if we do suspect something serious, okay, we're certainly going to help you through that process, and we can guide you to then see the necessary specialist or go back to your GP. But unfortunately, a lot of the time, physio is sometimes skipped as the first point of call. Okay, so I hope you're hanging in there in terms of all the jargon, but about to get a little bit more nerdier now. And we'll talk a little about pain science and the brain. So we know that pain is 100% of the time produced by the brain, and this is no matter if it's strong pain, if it's a weaker pain, dull pain, sharp pain, or no matter how long that you've had it for. And we like to think of pain as an alarm. It's an alarm system inside of you that's there to protect you. Um, and pain is a normal part of life. Okay, and it doesn't always mean that something is wrong. Um, think of pain as an alarm system that's looking out for any danger that might cause you harm. So say you put your hand on a hot surface. Okay, that's going to send a signal up to your brain, and your brain's going to, send a pain signal back down to hopefully take your hand off that hot surface straight away. To protect you, to make sure that you don't get hurt. So this is the alarm system, working well to help protect you and not get hurt. So most of the time, the pain alarm system is quite useful. So they kind of split pain into two categories. One is called acute pain, and this is where you've had like short-term pain that's more or less there for 3 months or less than that. And this is where it could be associated with tissue damage. Say you've strained a muscle in the back, that's gonna cause pain. But hopefully, as the tissue heals, okay, the brain will start to turn down that signal of pain, and you can get back to doing your day-to-day things. So this is the pain system working quite well. Now, when you have pain for more than 3 months, this is what they call chronic pain. And this is when it's less likely associated with tissue damage. And the main issue, um, sorry, um, sorry, tissue damage is not the main issue. As we know that most tissues in the body should be healed by that 3 month phase, or at most six months. So when pain continues for a long period of time, the nervous system has become sensitive, and it can change this natural alarm system that we had. Think of it like a sensitive car alarm that goes off. Say when like a leaf falls on the car, and the car alarm goes off. The leaf is obviously not causing the car any harm, but the brain for some reason thinks that it is. So due to this sensitivity, it can take less to trigger pain. So you now have a pain alarm system that's working, disproportionately to the danger that it detects. So you can imagine that having a brain that keeps on producing pain even after the body tissues are restored and out of danger is can be a bit of an issue. And this can be a hard sell to patients trying to explain this to them. It can be confronting to receive a message like this. And it can be normal for patients to say to us, "Oh, so you're telling me that my pain doesn't exist and that I'm making it up." And then they'll point to the MRI that they've just had done, and they'll point to a disc bulge that they think is causing their pain, saying, "I know my back is damaged and this is causing my pain." But please do not think that this message is about us saying that your pain is not real. Um, all pain is definitely real. What the hopefully reassuring messages that we're trying to convey here is that we do not necessarily need to fix any of these changes that are found on your scan to help with your pain. We can explain to you that most things in your body should be healed by about that 3 to 6 month mark. What we need to actually address is that sensitized nervous system that is continuing to send that pain signal. So this is what we kind of get into, what does cause this sensitized nervous system and chronic pain? And then you just really start looking at the sociological and psychological factors that can cause pain. So when your physical movement is limited initially by pain, say like a muscle strain of the back, this in itself can make you stressed and worried. Compound that with your personal health beliefs and coping strategies, having catastrophizing thoughts, believing that your back is damaged and fragile. This can increase the sensitivity and intensity of the pain, just like that sensitive car alarm that we mentioned before. So you can see why having an MRI, which shows a patient a disc bulge, probably isn't going to help things, as they will unfortunately catastrophize things even more. So other things that can sensitize the nervous system, influence that pain levels, poor diet, smoking, job stress, poor sleep, poor recovery. Okay, so we have to really make sure that we understand how all these factors can actually get that brain to unfortunately turn up that signal of the pain. And this includes those poor beliefs of the low back. So we touched on some of these before. All of these things can catastrophize those thoughts, and it can psychologically influence pain levels. So we know there's a stigma of low back pain in society. There's lots of negative stories of people in society, unfortunately, with back pain that can sensitize you. You hear things like, "Don't bend the back, my back is weak." This can just lead you to naturally just avoiding using the spine, avoiding bending and twisting through the spine. This just leads you to moving the back less and less, which increases the sensitivity of movement and pain. You hear things like, "My disc can slip, bending of the spine is bad. I have to always be careful when lifting." So the list really goes on about all the things out there that you hear that can really sensitize your pain. So if you have a simple muscle strain of the back, but your brain is thinking, all of this could really affect those pain levels and the time course of your rehab. So let's go through some of these um, some of these concepts, hopefully debunk these myths, and actually get you thinking more positively about your back. Okay, so bending of the spine is bad. It's a very common one. So this is the time where I thought it'd be good just to briefly just go through some of the anatomy of the low back. So we start on the right here. This is zoomed in, as you can see, there's a picture here of a full body. And it's zoomed in, looking at the side angle of the lumbar spine. So you've got five vertebrae, one, two, three, four, and five. Um, and you've got this intervertebral disc that is in between each one to help try and shock absorb the load. And on the left here, this is the front of someone, and on the right here, this is the back. So you've got the vertebral body at the front, okay, and then the bone protrudes out the back into what we call the spinous process. So if you were to press on the center of your back, you'd be pressing on this spinous process here. Okay, so I take one vertebrae here, and we go to the left. This is looking at one vertebrae pretty much from top to down. Okay, so this here is the front of the spine, and on the bottom here, where the spinous process is, this is the back. So you've got the intervertebral disc that sits right on top of here in this little space. Um, and you've got your spinal cord that sits right here in this space called the vertebral foramen. Okay, so you can see the spinal cord is surrounded all by this tough, strong, durable bone to help protect it. Now, so on the left here, so it just highlights all the different vertebrae that you have in your spine. You've got about 30 altogether that can flex, extend, and rotate. Now on the right here, so this is the first point I wanted to make about, the back was made to bend. So this again here on the right is looking at that side angle. So you've got the vertebral body here, you've got disc, vertebral body, disc, and as you go from front to back, you go to this spinous process here. So yeah, this here is the disc. So you can see these five color-coded things are your ligaments of your back. You can see four out of the five of them are behind the disc here. So each time that you were to bend forward or round your back, four of these ligaments would go onto a lot of tension, a lot of a bit of a stretch, if you call it that. Um, and what ligaments are designed to do is to help support movement. So you have four out of the five ligaments that are built into into your spine to support bending forward. Whereas if you extend backwards, there's actually only one at the front of the disc that helps to support that. So just based off four out of the five ligaments supporting flexion, it should really give you the sense that my back was made to bend with all these supporting structures there to help it out. This is the same thing that we see when we look at your muscles. Okay, so we're going to go through a few layers of the back muscles. Now, again, I'm not going to quiz you at the very end about all the back muscles that we have. Let's just give you an idea about how many muscles you have that help to support your back when you bend. So on the left here, these are some of your major large back muscle groups. So you might have heard of your traps before. This is in the red here. Your lats are in your green. Okay, very strong muscles that help to move like your shoulder and your middle of your back and your trunk as well. Then beneath that, you have another layer of muscle groups here. You can see here on the right, you've got muscle groups that go from the spine to the ribs, or from the ribs down to the pelvis. If we keep on going through the layers, you've got all these three other different groups of muscles that run parallel to the spine. So on the right here, you've got large muscles that run adjacent to the spine from your head all the way down to your pelvis. In the middle here, you have these muscles that pretty much link one vertebrae to the other like a chain. So you can imagine how much strength you have from that kind of interlinkage. And on the left here, similar story. So you have all these layers of muscle in the back. If anything, it's probably the muscle, or it's probably the area of the body that has the most layers of muscle, that I can think of. Okay, and all these muscles, again, when you flex or bend forward, all these muscles are going to tension with you and support you as you bend forward. So you have so many strong muscles and ligaments that are there to support you when your back bends. So to say that um, bending of the back is unnatural, is it's bad for you. It really is a mistake to say that when you think about when you look into all the anatomy and the structure of how we were built as humans. And the other one that we hear from time to time um, is I can slip a disc from bending the back. And this is a very annoying one to hear as a physio or a health practitioner, because your disc, it's not a bar of soap that's going to slip out at any point. Your disc cannot slip. Uh, it's not always injured from bending under load either. We actually don't know from all the studies that we've done, how a disc will actually behave in humans. Most pain that comes from disc injuries actually develops without having a incident, a specific incident. And this study here shows that heavy lifting only accounts for roughly 6% of disc-related injuries. We see that most people actually present with back pain of the disc after doing, something they would have done 1,000 times before. So experts can't agree on whether any lifting, strategy, picking something up off the ground with a flex spine or an extended spine, is more dangerous than any other kind of position. Studies will show completely contradictory results when measuring load at different spinal angles. And there's some even newer studies that are out there that suggest that loading rates are quite similar with a straight spine or a flex spine. And some even suggest that it might even be more load through the disc if you're with a straightened spine. And, regardless of all these models, you have to remember, that disc changes, like a disc bulge, are completely normal. If you remember back from that study we showed about all the incidental findings on a scan. Okay, because we know that we see them in almost any age group without any pain. And even if they are painful, we actually see that they often heal over time. So there's a study that I wanted to include here that looks at the amount of regression of a disc herniation. In other words, a disc herniation actually getting smaller and smaller over time through people that don't have surgery. So this article here, well, actually, it's called a systematic review, which is one of the most top quality articles you can really do as a researcher. You pretty much take 13,000 other articles, and of those, you only select 38 of the highest quality ones. Okay, and out of those 38 high quality studies, they were able to tally up over 2,000 patients who had non-surgical treatment. Okay, so conservative management of a disc herniation. And 1,400 out of those 2,200 participants showed a regression or a reduction in that disc herniation. So that equates to 63%. Okay, so this just shows how robust, how resilient that the back is, and that it can heal over time. But with all this evidence, with all the um, differences that research has found on lifting positions, none of it is super conclusive. And we don't know if any of these positions are worse than other ones. But based off this kind of evidence, we really shouldn't be demonizing or fearing flexing, especially under load. So where does this kind of leave us with like treating low back pain? So we know that treatment needs to be holistic. It's not just about the structure or the biological side of things. has to address those psychological and social factors that we talked about before. So we talked about sleep, diet, stress, and of course your perception of what the low back is. So for a rehab plan to work, it must address these factors. So thinking about how we can de-stress, eat better, sleep better, have more self-belief about our low back, being strong and resilient. And then it's all about, gradually exposing the back to movement. Hopefully the brain starts to realize then that these light movements are safe or will turn down that intensity of the pain. So it really just shows that education is a powerful tool. And that's what us as physios really try and do throughout our treatment of people, especially with chronic low back pain. Spend a lot of time addressing, the psychological and social factors, sometimes more than the actual biological state. But then we can start to, shift to that biological side of management of injuries of the low back. So let's say that we've taken someone, we've done the screening, they're in that non-specific low back pain category, so let's call it a muscle strain. Um, Still going to be very sensitive at first. Okay, the inflammation process has kicked in. All right. So at this stage, it's definitely reasonable to take some simple pain meds. Like Nurofen is a great one to decrease inflammation. Panadol for your pain. Okay, these just really help to desensitize that movement in the early phase. But it's always good to remember to make sure that you start with gentle movements. Don't sit down all day. Don't lie down all day. This will unfortunately just sensitize your brain even more, and it might turn up that pain signal when it probably doesn't need to be. So start with gentle movements. Teach the brain that movement is okay, and know that small amounts of pain are okay. Generally, it's okay if it's less than 5 out of 10. Because remember, from what we said before, pain is an alarm, doesn't always just equate to damage. And you can simply let this pain let this pain guide your increase in activity levels. So as you start to hopefully decrease in pain, you can generally just move more and more. But this has to be gradual. And this is where in physio, the manual therapy is often useful in this early phase. That hands-on massage, or some light joint mobilizations, things like heat packs. Just a great way to relax the muscles and just allow movements of the joints again. But then really after the acute phase, it's getting the back moving more and more. And this is where a simple loading principle comes into play here. Um, and that is tissue will gradually adapt to the load that you apply to it. This is all type of tissue. It's muscle, it's joint, it's tendon, it's even your bones as well. So if you don't use a tissue, okay, you're going to decrease its capacity. But if you gradually use it more and more over time, you'll increase its capacity. So that saying of use it or lose it is somewhat applicable in this situation. So it's really important to just get the back moving. Next time you drop a pen on the floor, don't just use your knees to bend down to pick it up, keeping your back straight. Just bend forward gradually from top to tail, and use the back the way it was designed to. A disclaimer though, just bear in mind, as much as I say, bend the back to pick up things, I'm not asking you to go and find the heaviest object on the floor and pick it up with a bent back. And the key word in this sentence is gradually. So you have to find your baseline, level first of what your back can tolerate bending. And over time, you can slowly, build it up. Okay. So yeah, tissue will gradually adapt to the load that you apply to it. So yeah, you've gradually increased your back's capacity to move. So I thought it'd be good now to just have a look at some simple exercises that can really help um, this this re or help your rehab journey of low back pain, or you might even just do some of these as a way to prevent low back pain, or if your back's feeling a little bit stiff. So these first exercises I put on this slide are more so around range of motion. So top left here, I call this one a cat camel. I guess it's the camel on the top, cat on the bottom. They also call the camel cow, just to make it even more confusing. But this is a really nice one at getting the back going from on the top here is a maximally extended position of the spine. On the bottom here is a maximally flexed position. So you can pretty much just ask the client to stick their bum out, stick their head out, and then do the opposite. Tuck your bum in or tuck your tail between your legs and try and look at your tail as well. Okay, so it's really nice at working that flexion extension of the low back. The one the bottom right here, in a similar way, works on extension and flexion. So this one here is the cobra in extension. This one here on the right, you can do a flow into this child's pose. So similar to the cat camel, it works in going from extension to flexion. And why these are also really nice as well to do, um, your back is in a horizontal position. You can imagine when you're doing this as opposed to, standing up where your vertebrae are stacked on top of one another. But when your vertebrae are horizontal, it's a lot easier to get some mobility without that added load through the spine. So this one, the top right here, again, the back's horizontal. This one's what they call a knee rock. So just rocking your knees from side to side. That can be a nice way to try and get some rotation through the lower back. But I've also included one in standing. Like, yes, it's a bit more load through the back, but even just, working on what they call this a roll down. So starting at your neck, flexing your neck, and flexing your thoracic spine, your mid back, and working your way, vertebrae by vertebrae, all the way down to your tailbone. This can be a nice one to do in the shower with warm water running down your back to really try and loosen things up. And in this slide is looking more so at exercises that help to strengthen the back, or not just the back, but all your muscles around the spine. So this might be done later in the rehab stage. Maybe pain is not as heightened, or you could have the goal in general. You might have no pain at all in the low back, but you just want to try and get everything nice and strong to prevent a low back pain onset. So on the left here, this one here is they call it dead bug, where you're pretty much straightening your opposite arm, opposite leg away from you. It's good at working your tummy muscles. Uh, this one in the middle here, they call a Superman. So this is actually working the muscles that take you into extension. So the muscles that extend your shoulder, your mid back, your low back, but also your hip extensors as well. So it's a really nice one that targets those muscle groups. And on the right here, this is a glute bridge. As the name suggests, it's going to target your strong buttock muscles, your glute muscles. You just dig your heels into the floor and lift your hips up. So of course, there's way more exercises than this, but just thought I'd throw a few in there. But this is where, if you have low back pain, or if you want to try and prevent from getting low back pain, seeing a physio is probably the best, first step you can do, because we can help guide you into an individualized plan that's going to try and select you the right exercises to try and get you as strong and robust as possible. I wanted to also just touch on quickly deadlifts. Is it a bad or is it a good exercise? Because I'm aware that a lot of people listening tonight do the Enero program at our practice. For those that don't know, Enero, it's an exercise class for people with low bone mineral density. It's aimed to try and get their bones stronger. Um, and we do a deadlift, and we pretty much teach it, how most physios, how most personal trainers would, with this image on the left, with this back staying nice and straight. Now, you might be confused because throughout this whole night, I've been telling you that bending of the spine is bad. Um, but in the class, we always tell you to keep your back straight and to not bend the spine. Um, so just to clarify, why we teach it this way, it really just comes back to the goal behind the exercise. So in a Nero, we're trying to strengthen not just the low back, but your hip joint, that bone of your hip as well. So we want to make sure we get good activation of those strong glute muscles around your hip. So when we do a deadlift like this here with a neutral spine, it's going to really target those glutes and your hamstrings a lot more. Okay. Whereas if we do a deadlift here on the right with someone just bending their spine, um, this is just going to target more so the low back muscles and not really target around the hips. So that's why we tend to teach it this way. And this neutral position, as much as we say neutral, you are actually still going to get some bend through the spine anyway, without you realizing it, without us even seeing. So you are going to load up the spine as well, which is okay because remember we want to load up the spine and those muscles to promote that bone adaptation. So really, at the end of the day, you kind of just choosing an exercise based off the goal. Okay, so that's hopefully gives you a bit of clarification as to we say keep the back straight in a deadlift because we're trying to get you to work the glutes and hamstrings more. But yeah, as I said, or as I've said tonight, if this was your goal on the right here, if your goal was to get the strongest ever low back muscles, then doing a deadlift like this girl is here, gradually building that load up over time would be um, most of the times okay. Um, like you may have to check with your physio. There might be other factors that won't allow you to do something like this. But that common principle we have to always remember is tissue will gradually adapt to the load that you apply to it. And just lastly as well, because I know I'm approaching 8 o'clock, um, just a little bit about posture, um, because in society, unfortunately, sitting gets blamed a lot as a bad posture. But really, a posture is only bad if you stay in it for too long. Okay, that's why sitting does get blamed because we unfortunately sit pretty much all day, every day at work, a lot of us. But if you imagine, if you flip it the other way, imagine if, most people stood for 8 hours a day. You'd probably get quite stiff and sore in the back and in other joints as well, just from standing all day. So really the key should be coming back to just trying to change your posture more regularly throughout the day. So that's where sit stand desks are getting more popular at work because they get people from going sitting to standing back to sitting. Okay, so I like to think of it as your next posture that you adopt is your best posture. Okay, so just try and just keep moving throughout the day. Don't try and stay in the same position for too long. So this here on the right, I just got this off Google Images somewhere. And on the left here, it did say healthy. I crossed it out because I didn't really like that, the way they labeled it. Because really all these postures here, some people are born with, like kyphosis. So like, rounding of their mid back. Some people are born with a sway back. So this fourth one here with a lordosis through their low back. I actually have quite a pronounced sway back or lordosis. Okay, but doesn't mean I have a bad posture per se. I move my spine regularly. I try and exercise regularly. I have positive thoughts about my back being strong, and I very rarely seem to get any pain. So the key is just to try and change your posture regularly, and just keep moving. All right. So hopefully, some take-home messages that you've received from tonight. Hopefully, you now know that the back is strong. Okay, hopefully you now know that the back is made to bend, and the back can heal just as well like any other body part that's out there. But always just make sure you recognize those potential psychological and social factors that could be contributing to your pain. Make sure you address those as well as trying to address those, that biological side. At the end of the day, one of my favorite sayings that I say all the time to people, no matter what pain, what area I'm treating them, is motion is lotion. Okay, you just got to get that body moving. Okay, you got 206 bones. Okay, lot of joints. Okay, just get that body moving, and it's going to thank you for it. All right, so I'm going to stop sharing the presentation now, and I'm going to open the floor for questions. I can see that it's just ticked past 8 p.m., which is good. My plan was to go to about 8 p.m. Okay, so hopefully I kept everyone together over that hour. Um, so feel free to yeah, pop a question in the chat bar if you want. You don't have to if you don't want to. If you need to get somewhere, then that's fine. We'll see you next time. Thanks for joining. But I'm gonna hang around for the next 5 to 10 minutes or however much longer we need just to answer some questions.